Okay, I think we'll get going. Dr. Kern's not here yet. He has a class that he comes over from, so he'll be dashing in here. But I do have a full hour of material, probably 5 hours of material, so we'll just be touching on it. So I don't want to take any time on introductions, so I'll just do my own introduction if that would be acceptable. So I'm Brian Sippy. I'm an eye surgeon here in town at the Rocky Mountain Eye Center. And we have basically a group of specialists. So this talk is going to be a little bit different than most of the talks on the lecture series this year, in the sense that the whole point here, well, not the whole point, but the big point is this, gigantic wealth chasm between the South and the North from our global system. And my talk is going to be very high-tech driven. So it's not going to be flashlights in villages in Africa looking for cataracts, which happens. There are those type of cataract camps and outreaches. But as a specialist, my goal with doing this Orbis program was to essentially do a high-end skills transfer. And the difference is we're going to their medical departments and taking their faculty and students and residents who are already at the graduate level and basically bringing their already relatively advanced program up to quote-unquote Western standards. So it will be a little bit different. Dr. Kern just arrived. Thank you, Peter, for running over from your class. I told him I had an hour's worth of stuff, so I was just going to jump in unless you had any announcements about the class.
I would like to introduce you, though. Could I do that still?
Okay, well, I'm kind of doing it. It's fine. So I'm happy. Yeah, I'm happy, Peter, just to tell him who I am. So I grew up in Kansas, a relatively small town about the size of Darby, about as far away from a bigger city as Darby is from Missoula, but the city was Kansas City, so a little bit bigger city. And I went to Kansas, did my undergrad, and I did a Bachelor's of Arts in Biology. And a lot of people do Bachelor's of Science when they're pre-med, so I felt it was important to have kind of more of a general liberal arts background. And then I went to USC in Los Angeles for my medical training. I stayed there for 7 years and did an MD PhD. And during my time there, I did have the good fortune of my first taste of basically, transnational competency, if you want to use those words from Peter's book. So I was invited by the president of the entire university to represent what we call the Presidential Fellows. They took 1 or 2 students from every professional school and built a class of 13 of us. And then we had an intensive program on our theme, our year, was how can Japan be in an isolationistic and homogeneous society compete in the global market with the United States? Heterogeneous melting pot. How can that even exist? And so our year-long fellowship culminated in a trip to Japan, and it was very exciting. And that was all in the context of a Kansas kid going to USC and having one of my interviewers tell me I had no business coming to Los Angeles, that I had no idea what the diversity was like and what kind of patients I was going to be dealing with, and I should just stay home. That was the director of pediatrics at the Children's Hospital in downtown Los Angeles. And then I looked down and saw his black shoes and his Harvard degrees on the wall, and I said, huh, you're out here running a children's hospital in Los Angeles? You look like you're from Boston. Yeah, I grew up in Boston. I said, what do you have any business doing out here taking care of these Latinos? You don't even know who they are. He basically said, let's just start this interview over. And I got a scholarship to USC. Okay, so this is kind of what it's all about, right? It's about people, it's about communicating. And then my training took me through Salt Lake City. That's how I ended up here. Just met a friend and wanted to live in the mountains, good clean living. And then I went to Atlanta and trained for 6 years doing my eye training. So completely different population, a lot of African American and immigrants, more from the African side as opposed to the Hispanic population and the Pacific population in LA. So I was in a meeting the other night with Peter and Delia and a few people, and I kind of made an arrogant comment about, you know, going away and training and coming back. It doesn't maybe afford much to the people coming back. It's not like they're going to bring anything back with them. And Peter said, we'll talk about that later. And it made me start thinking, you know, I was lucky. I was lucky to train in Los Angeles. I was lucky to train in Atlanta. I was lucky to go to these cities with VA hospitals and big county facilities where you're pushing your own patients to x-ray and you're tapping your own bloods and you're actually doing the work and actually interacting with the patient, laying hands on them, and not just writing orders that are going to be carried out and you never even see the person in room 106. So I'm lucky, and I need to have that in my perspective when I think about teaching and expanding experiences and role modeling, is that not all of us come from the same backgrounds and not all of us have the same opportunities. But if we're pulling on the same rope and have the same goals, then it certainly can all work out. So that's my introduction. Thank you, Peter. And, and so basically back to what I was saying. So this talk is going to be a little bit different. This talk is going to be more high-tech talk. But I think the purpose and all the ideas are still sound. This idea of interacting with different cultures with the goal of health, delivery, and well-being. So, as I said, I'll kind of clip along here. So Orbis is a company that has its main office in New York City, and it's celebrated, I think, its 75th anniversary. And basically, they're trying to, you know, prevent blindness worldwide is their goal. About 45 million people worldwide are blind. I'm going to tell you what those definitions mean, because when we think of blindness, we think of somebody in the dark. In the real world, that doesn't exist too many places, which is good. But we're talking about visual impairment and legal blindness and activities of daily living and what that all entails. But of this, most of this blindness can be treated or prevented. And so the idea is that let's try to go after what we can achieve and see if we can make the world better that way. So they're a nonprofit, non-religious group looking at global development, and whose mission is to eliminate avoidable blindness in the developing countries where 90% of blindness resides. And this is important. By strengthening the capacity of the local eye health partners to prevent and treat the blindness. So what I'm going to tell you is what I believe Orbis's main goal and why I even signed up with them and put my reputation with them is they're going to try to teach people how to fish. They're not going to buy them a fish. And I wanted to leave places not patting myself on the back saying, oh, I did 20 cataracts a day for 5 days. No, I'm wanting to go teach somebody to do something so I can leave and it can continue on, and that's what Orbis is about. So here are some statistics. This is a percentile. If there's 100%, this is the breakdown of where blindness is in the world. So China and India carry a lot of blindness, and again, reflective of a lot of the rural poverty and populations. The Americas are considered all of the Americas, North and South America. And so low vision and blindness. So low vision in our country would basically be a level of vision where you couldn't pass a driver's license test just straight up. With best corrected glasses, contact, LASIK surgery, cataract surgery, you couldn't quite get the 20/50, 20/40 line. That's low vision. Blindness is you barely can see the big E on the eye chart, again, best corrected, or your visual field is very restricted. Your world's a toilet paper tube you're looking through, basically. So again, dark blindness, truly in the dark, is relatively rare. But when we talk about visual impairment, we talk about low vision plus the blindness definition I just gave you. So now let's look at the prevalence. So again, prevalence is more per population. And so in the Americas, about 3% of people fit this visual impairment category. China and India are carrying 5%, Eastern Mediterranean, Southeast Asia. So I'm going to be talking a little about experience in China and a little bit about experience in Syria. So one of the things that we touched on in the introductory lecture by Dr. Kern was pollution as this chronic disease mediator. So this is where I was in Changsha, China in 2006, looking out of the hospital window. And these are some slums basically here with a lot of condensed housing. And this was like the clearest day of the week that I could even take a picture. And this isn't Beijing. This is basically Atlanta of China. So a little bit southeast, but not on the coast, kind of inland a little bit. So this is the hospital. In fact, this is a doctored up classic China Photoshop image. So it's all beautifully pristine with blue sky around the new hospital that they built. And then on the background, you can still see the pollution around the other buildings. So basically what happened in Changsha is the big government of China decided to make centers of excellence for healthcare delivery. And in this Changsha province, which is in the Hunan province, they built this hospital, this Changsha Hospital 2. And so literally they took all the patients and all the staff and all the equipment from this old dilapidated hospital and then just moved it across the street, quite frankly, into this Star Trek modern building. I mean, you cannot believe this building. I mean, all the automatic doors and lights and windows and the elevators, it is disturbingly cool. But you walk in the door and then the staff's the same and the patient's the same and the equipment sitting over the corners dilapidated, and it was just this incredible juxtaposition of wealth and modern technology without infrastructure being thought about. So part of our game here was, since they built this facility with the new operating rooms and all the new equipment, a lot of the staff didn't even know how to use it. And it was cutting edge stuff. And so Orbis's goal on this trip was to basically teach them how to use all the stuff they had at their disposal now to take care of the local population here in Changsha, which is a huge population. So basically, again, this team building and team success, I mean, it's going to mandate an understanding of our cultural hierarchy. So in China, luckily, I had had this Japanese experience, and there was a relatively good understanding for me walking in about what was going to be going on here. So she was basically a junior professor, and she was a fellow. And this is the department chair to be within a year. So I'm assigned really to her to teach her, but because she has a junior person to her, she's actually kind of passing the baton, saying, I realize I have the honor of being this Orbis trainee, but I'm already made. I'm already in the system. I'm already tenured, I guess, as you were, and she's our next in line, and so I really want you interacting with her. And I couldn't really directly talk to her about some of the protocol without going through him. So I had to understand who I needed to be talking to about what things. She was given permission to learn the medicine from me, but where I sat in the room and how we coordinated the surgery, that all had to be cleared by them. And so again, if you didn't understand that and you just walked in cold turkey and started doing your thing American style, that really wasn't going to work, and it probably wouldn't have been an effective team. Retina, my specialty is basically the extremes of life. I deal with the very, very young, and I deal with mostly people over 65. And so we're kind of examining babies. Again, that was the fellow, and she's helping me examine this child, and there's a lot of people in the room. And after we do our infant clinic, then we brought in our adult clinic, and these patients had been pre-screened. So Orbis has already been to Changsha a year in advance to set this program up. And multiple trips, multiple people going. The media campaign is set up. The fellowship is certified so that when we leave, the public is going to feel that these doctors are better because they were trained by Orbis doctors, so they're going to get a certification, and it's going to be a course that they're taking. And so all of this is set up. Well, as can be in China, they can be masters of duplication. And so the Orbis team told them how this tag system was going to work. And we get there, and there's about 300 people with duplicate tags. And so now we almost had to pre-screen everybody again because we really couldn't vet out who was the real patient and who was somebody just trying to snake themselves into the Orbis clinic to get cutting-edge care. It was actually just a fiasco. So anyway, here comes a legitimate patient, comes in with his little name badge there, and he has his son with him, and I'm going to be doing some screening. Well, this is the environment I'm in. So all of these people are either trainee students, medical students, residents, or fellows, or junior faculty. And so they're all listening through an interpreter here what I'm thinking real time when I'm examining the patient. I'm just talking out loud, talking to the patient and the son about what I'm finding and what we're thinking about doing. And once we all make an agreement that this is a good teaching case, out of the 50 we screened, we might have picked 7 that I'm going to operate on with them, and they're going to operate on with me. So once we agree, then I do all the documentation that's going to be complete, and we make the surgical plan. Again, I'm confirming the surgical plan with him first. And once he says, yes, we're all on board, my faculty and students know what you're going to be doing, then we'll start talking directly to them. Then after that, Hunter, my friend, who trained under me at Emory, is the medical director of the Flying Hospital. It's one of the ways I kind of got in on this gig. And so the medical director then approves what we're doing. This gentleman was an anesthesiologist who's volunteering his time from Houston. And so then anesthesia will clear the patient, make sure they're safe for surgery, and make sure they're understanding what's going to physically take place when we're in the operating room. And this was post 9/11. So even in China, at Changsha, we're taking these patients literally in their jammers from the hospital in a little shuttle van on a police escort to the tarmac, because this airplane is a flying eye hospital, and it sits on the tarmac. And so we had to get through security. And we were like, really? These guys are in their jammers. I mean, we've been here for like a week already. The airplane's sitting out there. What else is it doing? And we had to all go through security and take off all our belts and our shoes and all this stuff. Is a little ridiculous. Okay, so here is the hospital. It is a magnificent accomplishment. They took a DC-10 airplane and they basically just gutted it and they turned it into a hospital. And so they took all the basically first-class cabin area and a lot of the galley area and turned it into a lecture hall. So it seats almost 30, maybe 40 people up here in a lecture hall. There is a big flat screen television here, and then there's an audio-visual room. This system is designed that when the surgeries are being performed, they're real-time, live, being broadcast into this room. And there's a microphone out here for these observers to be able to ask questions real-time to the surgeon while he's operating. This is a little treatment room where there's lasers and other minor procedures. And then there's a hallway, you'll see a picture I'll show you here in a second, where you would get down to the pre- and post-op area. So patients would come in here and they would do their pre-op dilation of their eye, let's say, get their IV going, get numbed up, do whatever we're doing with them. They move into the operating room suite. We do the surgery. Again, it's all fed live. It's all being recorded on DVD, so you can leave it behind so they can look at it again and again. And then the patient might come out, and then they do their post-op recovery, and then they would go back to the main little area in the holding area. And so this is just a cycle. The whole back of the airplane is the communication center. You can imagine they have to get set down, they have to plug the airplane in, they have to get their Wi-Fi all up and running because the next program is going to be in Bangladesh, and they're talking to Bangladesh about what's going to be happening in 2 weeks when they're there while we're working real time in China. And so this is an incredibly sophisticated airplane. So here would be a shot kind of looking, so I'm standing right in as you walk in the air stairs into the airplane as if I'm looking down this way. And so the operating room's on the left, and if with some detail. You can see all these tracks up here. There are 6 independent cameras on a tracking system that the person can drive around. In case I'm hunkered down working, he can bring a camera so it's under here and he can zoom it in and zoom it out. There's cameras on the microscopes, and again, so the AV guys are dealing with this real time, and so it's like a multimedia center watching a live football game, cutting from camera, cutting to camera, and working there. So it's really cool from that point of view. Okay, so now I'm in the preoperative area. So here I have a preoperative nurse, and she's helping me translate to my patient, but I'm also teaching her how am I communicating with this patient, how am I giving the patient ease on what to expect, what they're going to feel in there, so things don't startle them. And again, a little bit of humanity. And so a lot of times culturally, you know, it's like toughen up, you know, just get in there and suck it up and lay still, lay still. And you're like, listen, if you just tell them what's going to happen, it's going to be a little different experience and they'll probably lay still. Okay, so then I was demonstrating a way to numb up an eye, and a lot of times you go right through the skin to make this little numbing injection, but that hurts. But you can cheat, and you can go around the skin, and you can still get the medicine in the same place, and it doesn't hurt. So I was showing him a technique where you can numb up a patient's eye in the pre-op area, and again, they're standing right there watching. So then back to this piece of equipment. This little viewing system hanging on the bottom of a microscope, $40,000 piece of equipment. And I'm going to show you, they had it sitting in a drawer. They hadn't even opened up the drawer. It had been in there like 8 months. They didn't know how to use it. So we had a similar one. We knew what they owned. We'd been talking to them for a year. So we brought one exactly like they had. And now I'm going to show them what it's like. So again, this is now my junior faculty. Here's her fellow. And we're putting this little device on the bottom of a microscope to help get a panoramic view inside of the eye. Instead of a high magnification view where you can just see a tree, I can actually see the whole forest when I'm working in there. It makes the surgery much safer so my instruments aren't damaging things and I kind of have a big panoramic view. This is modern medicine. I've had this in my hands for 20 years. Okay, they just got one and they didn't even know how to use it. So we're going to show them. So here's this little device hanging on the bottom, for example. It's one little device. So now I've got a microphone. I'm going to show you that in another picture. But I've got a microphone. There's a camera coming through the microscope so the people out in the lecture hall, all the department, can see what I'm doing. They can talk to me. She can help translate. She speaks very good English. She can translate back and forth to the fellow and to help me understand a question maybe if I didn't quite get it right. And so again, kind of real time, and it's all being recorded for them. So then again, this DVD, right when I walk out of the operating room, you know, I've never done this. I've never been on live surgery with the big lecture hall full of people. And I come out, I'm a little mentally tired. I think I'm going to be able to walk out, maybe walk to the back of the airplane and just decompress a little bit. And I walk out and the guy puts a camera right in my face and starts interviewing and asking me. And so his job, he's from Jamaica, and he's basically, he's getting his master's degree in kind of health media. And he's doing a fellowship with Orbis for a year. So again, this very kind of international, multiple layers of teaching and experience. So we have our technicians teaching our technicians, so an Orbis technicians kind of showing them how to handle suture, how to deal with things sterile in a sterile field. Again, they were kind of used to this older hospital, and so it was classic. You walk up to this little machine and you put your hands out and it puts soap in it, and, you know, and you come over here, and then after you do all this crazy thing in this sink that can read your mind, basically, they walk over and they open up a bamboo thing with their raw hand and reach in and grab a towel and dry their hands and throw it off, and they'll walk in the operating room. You're like, really? Who brought the bamboo thing over with the towels in it that's not sterile at all? How did it even get in the hospital? So again, just some breakdowns and some basic things, although it's very high tech. So now here's their little platform. So now we're at the host hospital. We went back to their hospital. We got off the airplane when I was operating. Now it's your turn. You're going to show me what you learned. So she's done the block, the technique I taught her. It's a little less painful for the patient. She's checking to make sure the eye is numb. We've gotten into the drawer over here and pulled out their viewing system and hung it on the bottom of their microscope. And now she's going to do the surgery, and I'm going to sit in the assistant's chair, and we're going to talk through it. So again, direct skills transfer. Now, the irony is that as soon as she walked out of this surgery, the chairman basically went and got her and took her away into a private room. And I was like, my God, what's happening to her? And they basically said, she's not going to tell anybody how this works. She's not going to tell anybody how to put it together until she shows the chairman how to do it. And once he understands it all, and it's not losing face, that somebody in the department knows something he doesn't know, then she can go tell everybody. Right? If you don't get that, break down. So then we had a closing seminar. Here's our chairman. And so, again, trans competency. What's a classic thing that happens? International leaders will come to the U.S. and they'll do a year or 2-year fellowship. Had many international fellows at USC and at Atlanta. What's the problem? They don't have a medical license in this country or any of the states. We don't allow them to even touch a patient. They can't document anything on any charts. So that's a breakdown in exchange, right? I can go over there and I can operate on their people, and they can come here for a year and they can't touch anybody. But what do they do then? They go home and they become chairmen of their departments because they were trained at Duke, or they trained at Emory, and they were a fellow. They didn't learn a single skill. They usually wrote a couple papers and hung out and looked over shoulders. But their English became more proficient. They usually mellowed out a little bit. And they kind of saw, again, how we interact with each other and how we're a melting pot and how we can talk to each other when we're not culturally the same. And so it breaks them down a little bit. And I've really watched people who are brilliant people who just want to knock the same square peg in the round hole, do the same technique on 10 different eyes, when you have to say, listen, you're smarter than that. Let's put this puzzle together and let's kind of think through it. So he was really cool. He'd spent a year in the U.S. He had hung out, in Duke, and I knew him, within just an hour talking to him. He was just a really nice guy. But again, I understood about some cultural things, and so I showed up prepared. So I told him I was going to give him a gift for being my host. And he was like, wow, you brought a gift for me all the way from the United States? And I said, well, isn't that customary? And he's like, well, yeah, but how would you know? And I said, because I thought about it, So again, little simple things really impressed that entire lecture hall full of people. They couldn't believe that an American brought a gift. Had a big, nice celebration luncheon at the closure. And this was a professor, cornea professor from UC Irvine, and that was me. Trish was from Thailand. She was an ophthalmologist, MD, PhD student at Stanford that came along with him, and then the entire department. So again, it's kind of this international team. She's working on her MPH from Taiwan. He's the MD, PhD from Stanford. We've got a guy from Peru, New Zealand, she's again Thailand, UK, and Jamaica. And these are all Orbis people staying on a full year with the team. Dr. Johnson was a plastic surgeon from Bascom Palmer in Miami. He's a really nice guy. He was fixing a bunch of cleft palates and eyelid lesions from trauma, dog bites, and stick injuries and stuff. Again, my friend Hunter, the medical director, with a kid that just had an eye surgery to correct a lazy eye. So then we went out on the town, so it's the local taxi helping me get around. I went to a very cool outdoor place with casual seating, but really high-tech cuisine. We thought we had the best food in the world, and then our cook came out to thank us, and we almost couldn't handle it. So a little bit different experience, but food was good. Okay. So that was China. So any quick questions? I'm going to tell you a very similar thing in Syria, but a couple nuances. Yes, ma'am.
I know how a number of the medical schools now are partnering with other medical schools and things like that, but how does Orbis make these connections with programs all over the world?
Yeah. Well, the question was, how did Orbis establish themselves and have these type of relationships? Part of it is 75 years of working on it. It's not a 10-year-old program. They're 75 years old, and they have earned trust. I can tell you, I wasn't even supposed to go to China. Unfortunately, the retina, I was too young. They usually don't let anybody go on a retina tour unless you're already 5 years out into practice. And I was only maybe 2. But Hunter knew me. I helped train him, and he's like, Sippy can do it. Unfortunately, the retina guy that was supposed to be there got diagnosed with cancer and couldn't go. So they got me a visa to China and all my paperwork in 7 days. That's how connected Orbis is. No consulates. They call directly. So they've earned trust in all these places. And selfishly, one of the reasons I was interested in Orbis is they can get me places I can't go. They can get me into Cuba and Mumbai and North Korea and China and Syria. Right? I can tour the axis of evil. So it's relationships and time and trust. And they have that airplane. It's like a little bit of a military camp when you sign up for Orbis for your year fellowship. That team of about 6 people can pack that DC-10 airplane up and be wheels up in less than 25 minutes. And the equipment on board is worth about $1 million. So it's not like you just take off with the lasers rattling and the microscope rattling. You have to secure it. They have taken off with people coming down the runway in jeeps and machine guns behind them with coups of military takeovers of governments and stuff. Yeah, it's not for the meek. These pilots are all like United and FedEx retired people, and they're very experienced. And yeah, when everything's going well, everybody's happy and smiling, but they say things can turn like that. So it's a little bit of a, you're out there. And you're in a high-tech airplane that's worth a lot of money that somebody would like to maybe take advantage of and capture it and try to leverage somebody, right? Yeah, so they're pretty, and they give us a little breakdown, like if this were to happen, this is what you do, and I'm like, really? Okay, so a couple years, there was another question, excuse me. Was there another question in the very back? Was it the same question? Okay. So a couple years later, I called Hunter, my friend, and I said, I'm interested in participating again. That was great fun, and will you have me? And he said, sure. What are you doing this year? The airplane goes around the globe every year, and it usually stops at about 8 places. And so I said, oh, it looks like Syria. I'll go to Syria, thank you very much. And so I got to Aleppo. We've heard all these names now, unfortunately, in our media. We're a little more familiar with some of this. But this would be an example of a volunteer team, right? So it was 2 two-week shifts with 3 MDs each. So Bill was from UC San Diego, cornea transplant guy, and we'll talk a little bit about the culture of that, donating eyes. They can't get an eye bank, right? A lot of religions in the Middle East aren't so keen on giving body parts when you die, because then you got to deal with being blind in your entire afterlife. So we got to break down these barriers if you're going to have any corneas transplant. Andrea, she's a champion. She's from Ecuador, and she's a pediatric ophthalmologist. They mostly straighten eyes, and she's just fantastic. And so this was our team of week 1, and then this was the team of week 2. So you can see even the team is kind of a little bit international. So here's Andrea and myself in front of the air stairs. So peds from Ecuador and retina from Montana. That's how it should be, right? So here's my host trainee and her senior mentor. He was an Egyptian who had moved to Syria to help start this first charity eye hospital in Aleppo. And so a classic thing is in these countries where there's no middle class is that she and he have their private patients that pay them cash, and they go see them maybe 2 days a week, and that's how they make a living. And then this charity hospital was a new concept, and the Department of Ministry got behind it, and they built this charity hospital, and they were volunteering their time 3 days a week at this charity hospital. But because there's no middle class, that reimbursement they get from their private patients is exceedingly high. So to only work 2 days a week, they actually are rich. So it's just an interesting dynamic. But back to the culture. So now we're in a pre-op screening. Well, here's the patient. So she comes in the room, and our interpreter's here helping, but she's insulted that Hunter and I are trying to talk to her. Now, you know, I got beat into my brain that you talk to the patient and you respect the patient She was insulted that we were talking to her. And her sister was standing out here, what's going on in there? Why are these men talking to you? So we had to go find her husband. He was out messing around. So we could talk to him. And it wasn't his deal, it was her deal. Okay, heads up, right? So now we're talking to him about what's going to happen and how this is all going to work. And again, she doesn't want us really even looking at her. I've got the bug, so I'm not looking too good right there. Okay. So now I'm going back in, they're micing me up. We're going to get ready for the lectures. But now we've got some VIPs on board. The department came, the director, the minister of health came. And this was a big deal. And also one of the Muslim leaders came. And the concept was get them on the airplane, show them what we're actually trying to do, and maybe again we can start affecting policy religious down, right? Get the clerics to say that it's okay to donate your corneas and things like that, and then let the minister of health become a believer, and then now maybe we can get something going. So, but again, cultural sensitivity, we have to pay attention. So she comes walking into a sterile OR with her hijab on. Well, can't wear that if it's not sterile. Now, if it's been cleaned, like scrubs have been cleaned and put away, but if you came from home in that, then you can't wear that. So she first walked in and I said, wait, I don't know if that's sterile or not. And they asked her and she said, no, I wore this from home. And I said, well, do they have any that are sterile? And they said, well, yeah, we have a couple. And so she went on and had to put clean clothes on, or I wasn't going to let her in the operating room. It's not proper technique. So she goes and puts it on, and so that was a whole lesson of the day. You can't cheat at the last minute. You can't just come in and say, oh, I'm wearing my street clothes into the operating room. It's not how it works. So again, I'm mic'd up, and I'm teaching the fellow, and we got technicians teaching technicians, and we're kind of going through it. We've got the Minister of Health. He's out on the microphone talking live to me, asking questions as he's watching the surgery. Again, relatively big audience up in the front of that airplane. And now we have our post-op instructions. So again, I'm talking to this guy who's not the best with English. He's trying to help me talk to this other man. Well, she is way more proficient as an interpreter, and she's a physician, and I'm trying to, but he didn't really want to listen to her. So then I asked him, does he have a sister? Yeah, I have 3 sisters. Do you guys play as kids and give each other grief and talk about, yeah. Do you think your sister loves you and wants the best for you? Yep. Well, she could be your sister, and I just need her to tell you something I need you to do. All right. Then you listen to her. And he's actually listening to her. He's like, oh, okay, now I'm in, I get it. So again, I got to have crystal clear communication with this level of health care, for sure. So now we switch out. So now my operation took an hour, but then it might take 30 minutes to get the room clean and get the next patient in there. So then I run out and I give a lecture. Because they're captive. They're on that airplane. They cannot get off of it. Okay, so, you got to be entertaining up there and dancing, entertaining and stuff. So I got to keep them entertained with lectures. We're asking questions, and then they're getting the other patient ready, and then I might go back and operate again, for example. So everybody knows Bashir, or everybody's heard, I'm not going to make any assumptions here. So he was training to be an ophthalmologist when his brother got killed in a car wreck. So he didn't have any interest in being president of Syria. He was not the oldest Kennedy. He was a younger Kennedy, and he was going off, and he was at Cambridge doing residency in ophthalmology. He didn't care about politics. Dad got leukemia. After he was sick for a while, the Parliament voted in his older brother. His older brother was in charge for a while, and he got killed in a car wreck. And they called him on the phone and said, congratulations, you're the new king. I don't want to be king. But now he's in this mess. So I don't know how to take sides. I can tell you, talking to these guys and meeting them, they seem to be so tolerant of peoples and religion. They're on the Silk Road. They have dealt with culturals things that you and I can't even comprehend. 10,000 years of different names and faces and languages. We're 200 years old. We're in our diapers compared to this part of the world. And I really can't, I just truly have to believe that he's just a puppet and a figurehead, and this is all behind the scenes, because he just didn't seem to be that guy, but who knows. So we brought this very cool machine with us. There were only 3 in the world. One was at Duke, and Orbis got one, and it's basically a virtual operating machine, super high tech on the airplane. And since he never really graduated and became an eye surgeon, we strapped him in the machine and let him do a little virtual surgery. And then again, you have to have fun and get out on the town. So here we have Bashar Assad here. And what is this? It's a Harley-Davidson dealership, middle of Aleppo. We got the twirling dervishes, we've got beautiful food. The presentation is always exquisite. And again, some of my host people taking me out for some live music. And then, as you see, there's cigarettes and lighters sitting on the table in front of 3 of the 4 physicians. Great. And then exploring the countryside, all these terrible names we're hearing about Homs and Damascus, and we're right next to Iraq. We went out to Palmyra and saw some ruins. They're beautiful. We got to meet some Bedouin people. Big drought in the late 50s and early 60s forced most of the nomadic farming, herding type culture into more jobs, but there are still a few pockets living in the customary beehive houses. They had us in for tea. And so Palestinians tend to wear this type of head garb, and so I wore it with him, a little Palestinian guide at the place at the ruins. And give you scale, this is my wife standing here. So these were big, lush palaces with palm trees, and the water system was exquisite back in the day, right? Probably built on the back of slaves, unfortunately. And so I'm really torn with what's happening today. It's just killing me, because it was such a beautiful place and beautiful people. So what's Orbis done since they've taken flight in this airplane in 1982? Well, they've trained about 300,000 medical professionals between nurses and physicians. They've treated optically or medically about 25 million adults and children. And we've performed about 1 million eye surgeries and lasers on adults and children over the time. And again, the thing that they're really working on is they're working with local and national governments, community-based organizations, and private sector to help its partners reach a state where they can provide on their own quality eye care that is affordable, accessible, and most importantly, sustainable. And the Flying Eye Hospital is just one little piece of Orbis's pie. They have a telemedicine volunteer cyber site that like I can log on and I can give advice on a case. They have their hospital-based programs, which is far the biggest part of Orbis. They probably have over 100 on-the-ground hospital-based training programs going all the time. This is a lot of glitz and glamour and razzle-dazzle and media, but this is where the hard work is happening. They have the long-term country programs. They have fellowship opportunities, and again, the volunteer faculty. They partner with FedEx to maintain the airplane, and United Airlines donates all the tickets to get the volunteer faculty around the world. And so it's orbis.org, and that's the end of a long day. We started at about 7 a.m. I think we finished about 7 p.m. So I think the thing that I have been most impressed with about Orbis, and being in Peter's class and being a guest lecturer and just talking about some of these things, is the reputation ophthalmology has with cataract camps. Now, I'm not poo-pooing cataract camps. They serve a purpose and they're getting better. But a lot of, was there bad outcomes? Was there infection? What was the infection rate? Did we make it better? Did we teach them to do anything better? So Orbis is going years in advance to set these programs up often, and then they all go back within. So all my patients were seen by fellows from Orbis, flew back to Syria a week after the program, a month after the program, and 6 months after the program. And they're looking for infection rates and outcomes and complications, and they're documenting it, and they're trying to, again, fill these holes and fill these gaps and see what went wrong or what didn't go wrong. And my goal is not to go do the most difficult case and impress them on what I can do. My goal was actually to pick classic teaching patients, bread and butter things that we can make a difference of. And I picked 5 of them, the same, for example, 5 of the exact same problem. Today we're going to learn 5 different ways to do this. And again, try to build their toolbox so they don't keep trying to hammer the same square peg in. Well, why does that culture exist? It's that hierarchy problem again. The chairman comes back with a new technique and says, this is how we do diabetic retinopathy surgery. And now they just do it the same way. Well, it's different in a 30-year-old than a 60-year-old, and it's different if the disease is mild versus advanced. And so, again, helping them think outside the box, help them give permission to get out of this cultural hierarchy, telling the chairman you need to give them permission to get out of the cultural hierarchy and let them think on their feet, real time, when they're in the operating room. Unfortunately, human tissue doesn't follow the textbook. In fact, I don't think I've ever found a case in the textbook that I actually did, because it doesn't exist. It's basically the ideal case. So that's the thing about Orbis that I truly admire, is that they set it up to succeed by a lot of hard work up front. They do a good job of helping us culturally transcend some of these barriers while we're there on the ground, and then they follow up to make sure that it's going the right way, and can they continue to help. They leave textbooks behind, they leave the DVDs behind, we leave our emails behind, and we've tried to build now relationships that will, again, continue to break these boundaries down. So I appreciate your time. I know this is a little bit different than some of the topics, but I think it still has a purpose in this type of course, and I'll be happy to answer any questions. Yes?
What is Orbis doing in terms of prevention, vitamin A and river blindness? And
Sure. So the question is, what is Orbis doing about preventative care and maintenance? So those are a lot of those long-term country programs and hospital-based programs. So again, this idea of a lot of these things are treatable and preventable. So, you know, they're going to be partnering maybe with the organization that's there to help with the vitamin A deficiency, and they're going to basically give namesake to a program that's pushing that, let's say, through the Ministry of Health. They would then certainly, you know, river blindness, again, what she's alluding to is a disease, an infectious disease that can scar your windshield, basically your cornea, the dome on the front of your eye that lets light in. Well, you can have a perfectly good camera, perfectly good film, perfectly good brain. You just got a bad lens on your camera. All I need is a cornea transplant. And you go from being literally blind to being 20/20, potentially. But if I can't come up with any tissue, because nobody in this country donates tissue, then I can't have an eye bank, and I can't fix river blindness after it's blind. So eye banking is a big deal, and it's a big religious cultural thing that Orbis is working on, and they're really doing a great job with that. As far as the infectious disease, of course, when you're running your medical clinics and you diagnose it, you know, you can treat it. Trachoma is another big disease with the flies in Africa. And so, but the problem is we have great drugs to treat these things, but if you're not treating the, you know, the whole region, you're not helping. So again, I'm not there to fix one person with river blindness, right? I'm trying to fix the whole problem if you can. So that's a good point. Yes, ma'am.
Where does Orbis's money come from? Are they endowed? Are they continually fundraising?
The question is how does Orbis get their money? Well, again, they've kind of earned their keep, but with 75 years of good performance. So they have big donors, big namesake donors. The thing I didn't touch on, which is critically important, I think, I'm sorry I didn't mention it, again, I could talk for hours on this, but when you get high tech like this, it doesn't do any good for a big company to donate a beautiful machine to take over to Syria if nobody can maintain it. It's going to go down in about 3 days, is what's going to happen. And if you don't have any biomedical technicians that know how to service this machine, then it's useless. They're going to go put it in the corner, and it's going to have an $80,000 box sitting in the corner. So Orbis takes biomedical engineers with them, and there was 3 of them on both of my trips. And you don't even see where they go. They just go back to some back workshop with the local biomedical people, and they tear down these lasers, and they build them, and they tear down the vitrectomy machines, and they rebuild them, and then they leave them with all the 800 numbers and international numbers that they can call anytime to get real-time service. And Orbis makes these commitments with their partners that they will continue to serve free customer service, basically, to any past Orbis program. So, yes, Chris?
It's interesting, the things you were saying about the transcultural competency, and especially about how you knew to take a gift when you went to China. And in Syria, it was a big issue about whether a female medical personnel could speak directly to a male patient. Yeah. How much training does Orbis do of the faculty who are going over and the other medical staff to try to give them sort of a jump on those kinds of cultural issues? And how much is left up to initiative like your initiative in finding out about what would be appropriate actions in China? And then my sort of follow-on question is, is the organization set up to learn? So after your experiences, is there someone at Orbis who asks you, debriefs you and says, what could we do better? And you say, well, tell people about how you...
What was my experience, yeah. Right. So Professor Musty's question was basically, does Orbis learn from us, and do we learn from Orbis? And then secondly, did they provide me any training, or did they provide their faculty? So the China experience was unusual because of that gentleman getting the cancer and me getting sucked in, 2 weeks notice or something insane. So Syria to me was completely different. I had packets of information coming to me. I knew who my mentor students were going to be and what their background was and things like that. They gave me links to even videos. And so it was up to me. I mean, they can lead the horse to water, but I had to read the information and I had to do it. And so if I'm interested in wanting to go and actually affect some change, it would behoove me to be prepared. So I think most of us are and were. So yes, I think they make a very good effort. They also have their full-time fellows that are on for a year. So let's say you graduated from your residency in Ecuador, and it's socialized medicine, so you're going to go out and you're not really going to make much money, and so you're not in a hurry. So you're going to do a year with Orbis, and you're just going to go be kind of the young person. Well, they assign one of those guys to each faculty, and so then they come to us and they start emailing us about the month before and really start, do you know about this? Do you know about this? Do you have any questions about that? When we get there, I'm going to meet you directly and we'll go sit down and talk about a few things. So I think they do a good job, but again, I think it is a little bit of lead the horse to water, so the person has to have some interest. I found that one of my colleagues in China just didn't seem to care even about that too much. He thought he was just going to go show people how to operate, and it wasn't so much about relationship building for that individual. So I'm sure you have good apples and bad apples and for role modeling. As far as did they learn from us or from me, or yeah, they certainly, that was part of that interview. And they stick the camera in your face, and of course then the medical directors sit down with all of us privately and ask, what can we do better? What couldn't we do better? Did somebody try to game the system? Was there somebody in their department? So like in China, I had one of the vice chairmen come to me and say, I have my sister-in-law who needs a laser and she's scared to have it done, but you're here, can you come do this? Well, I didn't know my role. I didn't know to say no or not say no, and I didn't know if I needed to be more respectful to her asking me this favor or honorable to Orbis and not do anything outside of my boundaries. So I basically went down the hall and met the sister and examined her, but I had put the word out, will you please go tell Hunter that I'm being asked to go see this patient? And so by the time it was actually happening, they came in and said, oh, hi, hi, and shook the hands and said, we don't do this. And so then they knew that there was somebody that was kind of trying to game the system a little bit, and so they kept an eye on that person, that kind of thing. So, yeah, little tricks. Yes,
Do you, with your students, the people you mentor, do you still have a relationship with them? Do you keep in contact and answer?
Yeah, I've fallen down on that, unfortunately. I did for a little while with China. Syria's program doesn't even exist. The hospital's not even open. It's probably destroyed. So No, so I don't know anything about what's going on in Syria. The China thing was okay. I kind of emailed her maybe for just a couple months, and then it just was not asking questions about care. It was just, how's it going? It just kind of tapered off. So I think it's probably individualistic. I wish that was a little bit. I think the chairman, the gentleman that had trained a year in Duke, I think if I reached out to him and said, hey, I was there in 2006 with Orbis, and I'm coming to China with my family, I mean, I think he'd be gracious and let me come visit. But again, I don't think he would email me daily and kind of say hi, that kind of thing. Yeah. Yeah, Peter?
Do you want to go again? And if so, where?
Right. So I called, and it's been since 2008. So I promised myself I'd try to do it every 2 to 3 years. My good friend Hunter, that was kind of my inside guy, he left his position, and so then I didn't really know anybody, and they changed a few personnel in New York. So I kind of just got out here and got a job, and it gets busy. But so I called back and I said, I'm back in, and I want to go to Vietnam. And they said, oh, we're going in June. And I said, oh, I got another thing planned in June. So it didn't work out. So I think I would be better here. I think if I think this is my next game plan. I want to really talk to them about their long-term hospital-based programs, because it's exotic on the airplane, but I've got to do it. And the waiting list is a couple years for some of the specialists. So since I've gotten to do it, I kind of feel like maybe the next guy can have an opportunity. But then lastly, I think this is probably, it's going all the time, so then I can just work on my schedule, and maybe it won't be such a tight timeline, and it's not only 3 days. I could probably stay a week or 2 weeks or what have you. So that's what I asked them. I said, keep me on the list for the Flying Eye Hospital for 2015, and I'll look at your schedule as it gets developed. But start thinking of me as one of these guys. And I can wear 2 hats in the eye world. I'm an anterior segment. That means the front of the eye. It's not enough to specialize in the eyeball. You have to specialize to the front of the eye or the back of the eye. So I'm a back of the eye specialist that actually maintained and kept all my skills for the front of the eye, and that's relatively unusual in this country. So I told them that if I go, or you bring me over to one of these programs, I can double dip for you. I can teach your cataract surgeons how to do that, and I can teach your retina surgeons, and I can be a 2-for-1. So I'm hoping to leverage that a little bit to get myself back in.
Well, I think you'd agree with me that this has really been a very, very interesting and informative presentation, and clearly Dr. Sippy is one of those Montana's people who are Montanans, mountains beyond mountains. So let's give him a round of applause.